Assisting in Cardiology Lecture Part 1. The following are the objectives that we will cover in this PowerPoint presentation. The anatomy of the heart. The heart is a continuous pump pushing oxygenated and deoxygenated blood throughout the body. Here you can see in relation where the heart is to the ribs and how it flows out of the heart through the aorta and into the heart via the vena cava. There are different layers of the heart that you should be aware of. The pericardium is the outside sac. It's a double membrane sac called the pericardium that encloses the entire heart. The myocardium, which is the muscular layer of the heart. And then there's the endocardium, which is the inner layer that includes the valves and separate chambers of the heart. There are four main chambers of the heart. There is the right ventricle here, the right atrium, the left atrium, and the left ventricle. The blood flows through the heart. The oxygenated blood comes in the pulmonary veins into the left atrium and then through the mitral valve here into the left ventricle. Once the left ventricle is filled, the heart beats and pumps the blood out through the aortic valve here into the aorta, into the rest of the body. It then goes through the arterioles and arteries into the capillaries. Once the oxygenated blood comes back into the capillaries, it becomes deoxygenated and then goes to the venules and veins. And the veins pump the blood back through the vena cava, the superior vena cava, and into the right atrium. Once the right atrium is filled, it is released by the tricuspid valve into the right ventricle. Once the right ventricle is full, which is usually simultaneously with the left ventricle, it will pump and the deoxygenated blood will be on its way via the pulmonary arteries. This is a picture of the coronary arteries. So the coronary arteries always branch off of the aorta, right above the aortic valve where the oxygenated blood is pumped through. So as soon as the oxygenated blood is pumped out of the left ventricle, it goes through the aortic valve, and some of that oxygenated blood then goes into the right coronary artery and the left coronary artery. The left coronary artery is usually more significant and larger in most people. The first part of the branch of the left coronary artery is considered the left main. You will hear that term, left main. And then it branches into the left anterior descending, which is to the front of the heart, and then the circumflex artery, which kind of wraps around the back. The purpose of the coronary arteries is to supply that myocardium with oxygenated blood. Heart conduction. So we just talked about the plumbing, which is the arteries. The conduction system is the electrical system. The heart contracts stimulated by specialized cells in the SA node, or the sinoatrial node of the myocardium that conducts electricity. The SA node starts impulses about 70 to 80 times per minute and is the pacemaker of the heart. Atrial contraction then passes over an area called the AV node, which is usually in the lower part of the right atrium, which pauses the impulse for a fraction of a second The charge is then sent down through the bundle of His into the Purkinje fibers of the ventricles, causing a contraction of the heart. So as you see here in the top right of the right atrium, we have the SA node, which is the pacemaker where all impulses start. And then it travels to the AV node, which is in the lower part of the atrium, where there is a brief stall or pause here. And then the electrical impulse goes into the bundle of His, which is in part of the septum of the heart, and then goes to the branches, which is the right bundle branch and the left bundle branch, and then into the Purkinje fibers. Risk factors for heart disease. So advancing age, men are usually more susceptible to myocardial infarctions earlier in life. Women are generally more at risk after menopause. Gender does play a small part in it as time goes on, and especially more recently, gender is becoming less of a factor. We are seeing heart disease more and more in women. Family history and race play a great significance in heart disease. People that are African American, Native American, Mexican, Hawaiians, or Asian Americans are at a significantly greater risk of heart disease. Lifestyle risk factors, we have smoking. Smoking makes the arteries sticky and the cholesterol stick and create plaques within the vessels, causing these patients to be at higher risk of a heart attack. High blood cholesterol, hypertension, sedentary lifestyle, obesity or overweight, and diabetes mellitus. In diabetics, the blood vessels shrink or become significantly smaller. Therefore, if there's any plaque or cholesterol buildup within the arteries, there is a higher occlusion rate and lack of blood flow. Coronary artery disease, the cardinal signs are angina or chest pain relieved by rest or nitroglycerin. Coronary artery disease is the formation of atherosclerotic plaques that narrow the arteries supplying the myocardium. The plaque builds up mostly related to cholesterol in the blood levels. Eventually, this plaque erupts due to irritating that myocardium and causes a clot or thrombus, which can completely block off the vessel supplying the heart, which can cause ischemia, and this is what we call our myocardial infarction or heart attack. So here's a picture of how it develops. You have your myocardium here and little fat deposits starting, and then the plaques, they build up as you can see here, and it narrows that artery. And what oftentimes happens is this plaque will erupt and cause a thrombus, which you can see the start of the thrombus here, which can eventually totally occlude this artery, causing ischemia. Diagnostic and therapeutic procedures. Myocardial infarction, or MI, is diagnosed by an EKG change. We signify it by an ST elevation. We also diagnose it by elevated cardiac enzymes such as a TNI or a troponin I, which peaks very fast. We can also indicate it by a CK level or creatine kinase level, which measures the amount of damage. The more severe the damage is, the longer it takes for the CK level to peak. Patients with MIs are hospitalized immediately. They are started on oxygen and continuously monitored by an EKG machine or monitor. Treatments include the use of thrombolytic medications and heparin to dissolve coronary artery blockage and to prevent permanent myocardial damage. Aspirin is one of the main medications used in these instances. And we provide encouragement and reinforce the importance of lifestyle changes to prevent problems in the future. The faster these patients are treated, the less damage there generally is. Generally, we say within 3 hours of treatment will minimize the damage. Some of the treatments and medications that we will give are nitroglycerin, I already mentioned aspirin. Beta blockers will decrease the heart rate, which will decrease the blood pressure and workload of the heart during injury. And Plavix is a platelet inhibitor. We also, during a heart cath or stent, will give integralin, which is a thrombolytic clot buster, to help minimize that damage. Signs and symptoms of an MI in women, so abdominal, neck, shoulder, and upper back pain, and jaw pain. These two are the main indicators for myocardial infarctions or heart damage in patients, and can often be mixed with GI symptoms and can be missed. Shortness of breath, vertigo or dizziness, sweating, indigestion or nausea and vomiting, and extreme fatigue or aching in both arms. It's important to remember that all patients have different symptoms. So if one patient could have one of these symptoms and another patient could have none. So it's very important to treat all patients the same when triaging their calls when they are calling. Hypertensive heart disease. Chronic hypertension can be caused by ventricular hypertrophy or left ventricular hypertrophy, also called LVH, angina, myocardial infarction, heart failure, stroke, and neuropathy or kidney disease. Risk factors include family history, high cholesterol, smoking, high sodium intake, diabetes, excessive alcohol intake, sedentary lifestyle, obesity, aging, stress, and race. Symptoms are few, if any. Sometimes they will have severe headaches if the blood pressure is too high, or an increase in anxiety. Teach the patient to take blood pressure at home and provide information on changing lifestyles to manage the condition. A lot of times we tell patients about the DASH diet, limiting salt intake, fluids, that sort of thing, eating a low-fat diet. A lot of times with hypertension, we are treating this first with diuretics. It is important to recognize primary hypertension versus secondary hypertension. Secondary hypertension is due to another illness or disease. Idiopathic or primary is with no other disease present. Telephone screening for chest pain. It's important that you note what kind of chest pain it is. Is it crushing, pressing, or radiating into the arms, upper back, or jaw? A lot of times with heart patients that are having a myocardial infarction, the pain will be a pressing or crushing, or a lot of patients will describe it as an elephant sitting on their chest. A lot of times they do not have sharp pain. A lot of times the sharp chest pain is due to anxiety. It's not necessarily related to the heart, or it can be due to respiratory problems. Sometimes if there's a lack of fluid in the diet, those membranes can be dry and rub and cause a sharp type pain. Sweating, difficulty breathing, nausea, indigestion can also go on during chest pain, and dizziness. A lot of patients tend to blame their GERD or indigestion when it's really a heart problem and can get these symptoms mixed up. Any of these symptoms, along with history of coronary artery disease, myocardial infarction, or angina, need to be reported to the physician immediately. A change in pattern of angina, chest pain that occurs when resting or with minimum exertion should also be noted. A lot of times, if patients are having acute chest pain and it's not being relieved by nitro, we are automatically referring them to the emergency room. These types of patients we do not want to be seeing in our clinic setting. We need those emergency tools available in case they do end up crashing. Congestive heart failure causes fatigue, weakness, exercise intolerance, shortness of breath, and sensitivity to cold temperatures. It occurs when the myocardium cannot pump adequate blood to the body, usually due to weakness of the left ventricle due to a previous myocardial infarction where that tissue is now dead and unable to pump. Heart failure initially occurs on one side of the heart and then on the other side. Non-pharmaceutical treatments limit physical activity, limit salt. Usually we say 2 grams of salt or less in the diet a day. Also fluid restriction, less than 1 liter or less than 8 1/4 cups of fluid a day. This includes your jello, soups, anything that you were to drink. Eliminate smoking, stress that you may encounter, and decrease weight if you are overweight. Drug therapy that can often be prescribed is diuretics to decrease the workload of the heart, ACE inhibitors, which also decreases the workload of the heart, and oftentimes these patients need potassium supplement because the diuretics deplete the potassium, which can affect the heart rhythm. It is important for patients with heart failure to repeat sudden weight gains, so 5 pounds in 3 days or 3 pounds in 1 day. Those patients need to be calling into the office. A lot of times they will have associated symptoms with those weight gains. Extreme short of breath, fatigue are usually the most common symptoms that they have with those. Orthostatic or postural hypertension, if a patient experiences a drop in blood pressure upon standing. So a lot of times this happens in our elderly people, which leads to falls and breaks. Check the blood pressure in the patient while seated and then upon standing. Due to blood pressure pooling in the extremities or a reaction in medications or prolonged immobility can be the causes. Rheumatic heart disease is the most common cause of valvular damage in some of our older patients and can be asymptomatic but can lead to serious complications. Rheumatic heart disease is an unusual immune reaction that occurs within 5 weeks after having untreated beta hemolytic streptococcal infections. We are more aware of our strep throat infections today, and we are treating them faster than what we used to 20, 30 years ago. Causes an inflammation in the joints, skin, brain, and heart, and can scar the heart valves. Endocarditis can occur, or inflammation in the inner linings of the heart and the valves, causing stress on the heart. We use antibiotics to eliminate the strep infection completely and an anti-inflammatory agent to decrease the inflammation, especially if there's endocarditis present. The most commonly effective valve in rheumatic heart disease is the mitral valve. Valvular disorders may be caused by congenital defects or infections such as endocarditis. A lot of times we will see some of our congenital defects such as a bicuspid aortic valve. Aortic valves are supposed to be tricuspid. Valves can be stenosed, hardened, or restricting Valves can be stenosed or hardened, which restrict the forward flow of blood. This happens over time, especially with our patients with high cholesterol. Valves can be incompetent, which means it does not close completely, so there is leaking or backward flow or regurgitation. Oftentimes this happens with our mitral valve, that valve between the left atrium and the left ventricle. Most of the time when there is severe damage or stenosis, it will lead to repair or replacement. A lot of times we will try and repair the mitral valves. The aortic valves are most commonly replaced with a PIG valve or a mechanical valve. PIG valves do not last as long, but the Coumadin therapy is only 3 months after placement versus a mechanical valve where they do last longer. However, the Coumadin therapy is lifetime. A lot of times the mechanical valves can last up to 10 years. And if a patient takes really good care of themselves after, they can last for even longer than that. And this concludes part 1 of assisting cardiology.